Hey, thanks for choosing BrainWaves. After the episode, take a look at our iTunes archive for other great content, and check out our new website at brainwaves.me. Now, on to the show.
There was an interesting case report I read of a very unusual, atypical kind of cryptogenic stroke patient with multiple possible etiologies. The patient was a middle-aged woman with both an underlying malignancy as well as a compressed renal vein with compression of the inferior vena cava, as well as a PFO. And she ended up receiving anticoagulation systemically for having an associated DVT, as well as an IVC filter and a closure device with the amplatzer. And I thought that might have been a little bit overkill, but the argument, and perhaps rightfully so, was that the IVC filter itself may only prevent clots greater than 3 to 5 millimeters in diameter, and the middle cerebral artery diameter is less than 5 millimeters, so perhaps small clots could get through the IVC filter, especially after the filter is removed. They could pass freely and then cross over into the systemic circulation to that PFO. Welcome back to BrainWaves. I'm Jim Siegler, and today I will be talking with Dr. Christopher Favilla. So thanks so much for joining us on the show today, Chris.
It's great to be here. Thanks for having me.
Chris, can you kind of just talk me through how we've thought that PFO is related to stroke?
Sure. So, mechanistically speaking, the general thought is that PFO provides a potential for a right to left shunt. The majority of physiologic conditions with high left-sided cardiac pressures, that potential space is force closed, but during sensations like coughing or Valsalva maneuvers or a number of pathologic conditions, elevated right-sided pressures allow for transient shunt from right to left and allow for what's thought to be referred to as paradoxical embolism, or a scenario in which clot from the venous system can bypass the pulmonary circulation, go right to the left heart, and embolize out systemically throughout the body. It's also plausible that the potential space generated by this PFO between the septum primum and secundum provides the potential for some increased thrombogenicity along the septal wall. That at least sort of sets the stage mechanistically as to why we think that a PFO might cause a stroke.
Are there any data to support that Valsalva or increased right heart strain actually are causally related to the development of stroke? Have there been reports that Valsalva before stroke in patients with a PFO may be related?
Interestingly, that's probably the best argument that helps explain why the vast majority of patients we ever see, and we presume that the PFO is pathogenic of the stroke that we're seeing them for, is that there are some, in the era of high-resolution echocardiography, we're able to see that there is some normal right-to-left shunting in patients who have PFO during normal components of the cardiac cycle, so independent of Valsalva, independent of coughing. Not only that, but the fact that some of the edge of the PFO itself may be a bit more thrombogenic, the atria itself may be a bit more thrombogenic along those edges may also help to explain why. Maybe you don't even need a paradoxical embolization. You can just have embolization from a thrombus formed along the atrial wall itself. The real relationship between PFO and cryptogenic stroke is mostly pulled, as you pointed out, from retrospective studies. The pretty low event rate of stroke in the PFO community really makes this an entity that's best studied in the case control environment. And unfortunately, or perhaps fortunately, because it doesn't happen so often, that is stroke, it makes it very hard to study it in a more robust model like a cohort or prospective study. So this is largely case control data, and there have been mixed results from prior case control studies. The most powerful finding, the most robust finding, seems to be amongst cryptogenic stroke patients that are particularly young, where there seems to be, as you pointed out, that really potent relationship between presence of PFO and cryptogenic stroke. As patients get older and older, it seems like that relationship washes out a little bit. That's largely thought to be because of the accumulation of other vascular risk factors as we age that may be more implicative in the context of that stroke. Really, to get to the base of this, I think practically speaking, when you have a patient in front of you who has a cryptogenic stroke and who has a PFO, the question you want to be able to answer for your patient and really for yourself is whether or not that PFO is in fact pathogenic. One tool that's particularly useful is something that came out of the ROPE study, and they've generated a subsequent ROPE score. This is the risk of paradoxical embolism study, the abbreviation from which ROPE comes from. And really what they've done is they've merged a number of studies. These are 12 cohorts for a total of over 2,500 patients that have been pooled to generate this risk stratification score. And at the end, the score basically generates a probabilistic outlook as to whether or not that stroke that you're looking in front of you came from the PFO or not. And as you might imagine, the score is sort of a list of other vascular risk factors, age, other things that accumulate. And really, at the end of the day, what it's telling you is that young, healthy patients without other vascular risk factors who've suffered a cryptogenic stroke and have PFO, it's more likely to be pathogenic in that patient. In contrast to an older individual with a number of other vascular risk factors, it may be less likely to be pathogenic in that circumstance. But the ROPE score is a very effective tool to sort of put a number on that for you and for your patient.
Say you do the lower extremity Dopplers and there doesn't seem to be any deep vein thrombosis. How do you medically manage these patients?
Sure. So there's I think two schools of thought. One is medical management and then one is procedural surgical management. And I'm sure we'll talk about that next. But from a medical perspective, the question is a simple one. It's really whether or not you want to place the patient on antiplatelet agents or whether or not you want to anticoagulate them. First and foremost, we can pull from the WARS trial, which is, of course, a prospective randomized trial looking at the comparison of aspirin versus warfarin for secondary stroke prevention, and that's all comers. So you'd have to take a subgroup of WARS to pull the 265 patients that had cryptogenic strokes. Or not only that, but we want to answer the question for cryptogenic stroke patients, those of whom had a PFO. So if you look at that subgroup analysis, there does not seem to be a difference in the stroke recurrence rates between aspirin and warfarin going forward. So again, that would argue not a big difference between anticoagulating them or using antiplatelet. But again, the numbers are small, the data are very imprecise with huge confidence intervals, and point estimates might suggest that warfarin is a bit superior in that circumstance, just didn't reach clinical statistical significance. Thereafter, the PFO and cryptogenic stroke study, or PICS, another prospective randomized trial of aspirin versus warfarin in cryptogenic stroke. And in that circumstance, again, there was no difference in the treatment, whether it be aspirin or warfarin for those patient groups. Interestingly enough, in the PIC study, we always talk about how PFO increases their risk of stroke. If you look at those with and without PFO, there actually was no increased secondary stroke risk in the PFO group itself. So it almost makes you feel like if there's any benefit to warfarin, it might be in any stroke regardless, not necessarily in the context of PFO.
And that study was not limited like the subgroup analysis of WARS, where there were only 98 patients. There were almost 1,000 patients in the PIC study, so it's a little bit more power to perform that analysis.
That's absolutely right. It certainly was.
Why do we think that the closure is going to be superior to anticoagulation?
If it's a patient who's at risk of venous clot and subsequent embolization, closure might prevent paradoxical embolization, but would still leave that very same patient at risk of PEs and venous emboli to the pulmonary system, which is obviously of significant importance, even if that doesn't bring the patient to the care of a stroke doctor. The real idea is that this might spare those individuals, though, of needing to be on anticoagulation from the perspective of stroke prevention.
Okay, and now let's move on to the surgical management. So what kind of surgical options do you consider in patients with PFO and a cryptogenic stroke?
I think first and foremost, we can at least comment on open surgical management, we can open cardiac surgery for closure. And that's rarely done and largely only done in populations where open cardiac surgery is indicated for an alternative reason at that point in time. By and large, when we're thinking about this on the stroke ward, we're thinking about percutaneous closure. Percutaneous closure has obviously been a hot topic over the past several years and has been the topic of 3 prospective randomized trials for the purposes of secondary stroke prevention. Closure 1, which was a sizable randomized trial looking at almost 1,000 patients with cryptogenic stroke and PFO. And worth pointing out that patients in Closure 1 were first closed with the NMT Medical StarFlex device. These almost 1,000 patients were randomized 1-to-1 to either medical therapy or closure. Medical arm was basically treated with either antiplatelet or anticoagulation at the discretion of the treating physician. And ultimately, there were no significant differences in secondary stroke rates between these groups. Worth pointing out that the event rate itself was exceptionally low. What we did find was that the device itself carries some significant risks. There's a few percent risk of, about 3% risk in this particular study of significant device-related complications, which include things like cardiac perforation and significant hemorrhage. And also the device itself seems to increase the risk of subsequent development of new atrial fibrillation, much higher in the closure arm as compared to the medical therapy arm. Thereafter, a very similar trial, the PC trial, looked at a St. Jude device. It's called the Amplatzer device. Again, randomized very similarly to medical therapy at the discretion of the investigator versus closure with this alternative device. And again, no significant difference between treatments. And again, seems to be a few percent complication rate, and also seems to be a slightly increased risk of atrial fibrillation in the closure arm itself. Very similar trial, the RESPECT trial, but about twice the size, 980 patients. Again, randomized to medical therapy at the discretion of the investigator, and closure with the St. Jude device, very similar to the PC trial device. And once again, found that there was no significant increase in stroke rates in the medical therapy arm as compared to the closure arm, even though it does seem like the point estimates seem to favor closure.
One thing that I found very interesting about the RESPECT trial was that the analysis of their primary outcome was not significant, but in the per protocol analysis, they did find that there was a statistically significant benefit over time to closure.
And the post-hoc analysis has some validity. I think in this particular situation, the value is that the dropout rate and crossover rate is so wildly high in these studies. I mean, we look at the event rate, which is incredibly small, in the order of a couple of percent, whereas the crossover rate in RESPECT in particular, there was 9% of the closure arm dropped out of the study and twice that of the medical therapy arm dropped out. So you have such a huge number of patients that are either dropping out or crossing over. The post hoc analysis, for that reason, does have some validity. I mean, it certainly maybe at least sheds light on the fact that there may actually be a benefit there, right? There was statistical significance at that point in time. It's hard to take post hoc analysis and say that it puts a stamp of sort of definitive benefit of therapy there, but it certainly opens your eyes to the possibility and at least makes us think about this a bit more seriously in subsequent study.
With that being said, we would interpret the Amplatzer device as being potentially more favorable in terms of recurrent stroke reduction compared to the NMT Medical Starflex device. In follow-up pooled analyses of the trials that used the Amplatzer device, did we find any data to support that surgical or percutaneous closure is better than medical management?
So a pooled analysis of the two trials together, again, as you pointed out, because that puts almost 1,500 patients together in one place who use the same device of closure and very similar protocols, there seems to, again, be the same suggestion of benefit to closure. Still, event rates are incredibly low. Magnitude of effect is small. The data are imprecise with wide confidence intervals. We're talking about a stroke recurrent risk of 2.2%. This is really quite small, and again, crossover rate and dropout rates are incredibly high, right? We're talking about crossover and dropout rates about 8 times the height of the actual endpoint we're trying to measure, which is stroke. Makes it very difficult to sort of have any strength in the evidence itself. I think really at the end of the day, what this means for our management is to say that the strength of the evidence is not there that can allow us to confidently make a recommendation for closure for these patients. What it does is sort of open our eyes to the possibility and perhaps emphasizes the need for additional studies in the future, particularly with attention to the issue with dropout and crossover and trying to address that in future studies to allow for slightly more powerful evidence. I think there's hope that maybe one of these closure devices will make it clear that it's superior to medical therapy. At this point in time, I think the truth of the matter is that the associated 3.5% significant adverse events perioperatively from the Amplatzer device makes it very difficult. Between the debatable efficacy in conjunction with the significant procedural risk, it just makes it very challenging to endorse percutaneous PFO closure in patients with cryptogenic stroke at this point. I think future studies might convince us otherwise. We will see as we can continue to place these devices in more and more safe manners, but right now it's just very hard to look at this data and confidently endorse the use of the device in our typical patients with cryptogenic stroke and PFO.
All right. Is there anything else you'd like to add before we close up?
No, I think that's good. It's been a great talk.
All right. Well, thanks so much for your time. Again, that was Dr. Christopher Favilla, a vascular neurology fellow at the Hospital of the University of Pennsylvania. Really appreciate your time.
Thank you for having me on. I appreciate it, Jim.
Thanks for listening to BrainWaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com. Be sure to check out our iTunes archive for older episodes. This episode was produced by Jim Siegler. Music by Lee Rosevere. Marcos H. Bolanos. I'm Erica Mejia. Join us next time for another edition of BrainWaves.